So although these topics are very simple and these are basic, but as I have again and again emphasized during my lecture series, these are the topics or these are the disorders which you would be encountering in your day-to-day practice. So no matter what specialty you pick up, but still you would be having patients who are around you in your neighborhood, your friends, your relatives, who would be consulting you, and most of the time the consultation is going to, it is going to hover around your GI disorders. So that is why even if you are not picking up gastroenterology, you're not picking up medicine, but still you should at least have some basic idea about your GIT and how the derangements in the physiology of GIT can lead to GI disorders. So basically how or why this is clinically relevant. For that, I'll again begin my lecture with a case history, and this time it's a case history of a patient by the name of Meenal. And now this Meenal is 33 years old and she is teaching in a reputed pre-medical coaching institute of Delhi. Now, when I tell you about any case history, I'm usually starting with the name, I'm telling you the age, the gender, and as well as the profession, right? Because a number of disorders you can also link with the profession of a person. These are stressful days, stressful times, stressful professions. So all this can lead to, some kind of a stress disorder, which in turn can manifest in a number of ways, right? So here you have a patient by the name of Meenal, who is 33 years old. She teaches in a reputed pre-medical coaching institute of Delhi. Now, what are her chief complaints? She presents with the chief complaint of extreme fatigue and weakness for the last few weeks, right? So she has been feeling tired, extremely tired, and she's been feeling extremely weak for a couple of weeks. Another concern of hers is that she seems to be hungry all the time, right? So all the time she wants to eat something. She always keeps on thinking that why am I so hungry? And despite having hunger, she keeps on losing weight, right? So again, her complaints are basically that she feels tired, she feels weak, she feels hungry all the time, and she is having an unintentional weight loss. She doesn't want to lose weight, but somehow she's losing weight and she doesn't know why that is happening. So she attributes her symptoms to stress because she's teaching in a coaching institute and stressful times, and she's, maybe she might have had some family problems or she might be having some professional problems. She says that I'm attributing these symptoms to stress. She says that she's been feeling depressed lately because of the death of her mother, which happened 2 months back due to COVID, right? So now you can see that she's giving you a pretty good history. She also mentions about her intermittent bouts of diarrhea with foul smelling stools. Intermittent means which is occurring off and on, right? So she is also telling you that that she's telling you that she keeps on having these bouts of diarrhea. She keeps on having episodes of loose stools, and these stools are pretty foul smelling. They are foul smelling stools. And lately, she has noticed that everything she normally eats tends to make her feel bad. And she's kind of feeling bad all the time, right? So she's saying that although she feels hungry, but whatever she eats, that eating again makes her feel bad, right? So this is, you have the chief complaints in which you have a 33-year-old teacher, female teacher, who says that she feels extremely weak and extremely fatigued for the last few weeks, and that she's hungry, feeling hungry all the time. She's having unintentional weight loss. She's attributing it to her stress. And she's also saying that this stress can be because I'm also feeling depressed because of the death of her mother, right? And she says that she has been experiencing recurrent bouts of diarrhea, and these stools are foul smelling stools, and whatever she eats makes her feel bad, right? So now you go ahead and you'd start talking about her daily intake, because today's lecture is based on the digestion and absorption of nutrients. So this is the reason why I've taken up this case history, is because there is something which will lead to indigestion, or which would lead to the problem in absorption, and in turn it is leading to some problem of assimilation of nutrient, right? So you want to ask about what she normally takes daily, right? What is her normal daily diet look like? So her typical daily diet, it comprises of whole wheat chapatis or bread. Of course, we are North Indian. She's staying in Delhi. So her staple diet is basically that she eats rotis, or she eats chapatis, or she might be having bread in her breakfast. Along with roti, she has pulses, seasonal vegetables, salads with dressings, and soups. She also says that she occasionally eats non-veg food and also drinks beer, right? So she eats non-vegetarian, and she takes, you could say she's having, she consumes beer also, maybe with her friend circle, or during some festival time, or during some celebrations. So this is what she's giving you, right, in the history. In fact, she says that she's particularly fond of pasta, burger, French fries, and processed foods. Now, these are the various types of foodstuffs which we normally eat, and each of the foodstuffs would be having certain ingredients, right? So, again, you have to pick up from the history what are the pertinent points which can lead you to a diagnosis. She mentions that for the past few days, she's been having mostly egg, fruits, nuts, and veggies, and she's not feeling well, because she says that whatever she eats makes her feel bad. So, by her own experience, by her own trial and error method, she's come to the conclusion that if she doesn't have roti, if she doesn't have bread, she doesn't drink beer, she doesn't have processed food, etc., she's pretty, she would be pretty okay. Uh, Meenal also gives you a history that her mother always had GI issues and also had problem maintaining her weight, right? So now you can see that she has a genetic predisposition to her ailment, although it has appeared late in her life. Probably if you have some genetic predisposition to a disorder of this kind, it should have manifested in the earlier life, but here it is manifesting in the third decade of her life. And she also says that her niece, that is her sister's daughter, has been recently diagnosed with celiac disease, right? So now you can see that she herself has given the diagnosis, right? So she herself has, you don't have to think much about it. She's anyways given you the diagnosis also, that her mother also had GI problems. Her mother also had problems maintaining her weight, and that recently her niece, that is her sister's daughter, has been diagnosed with celiac disease, right? So you do her clinical examination. Whenever you do a clinical examination, again I'm emphasizing, you start with the general physical examination first, right? So on examination, Meenal appeared thin and concerned about her unintentional weight loss, right? By her general physical appearance, you can say that she was thinner, or she was slimmer as compared to her normal counterparts. Her pulse rate was this is what you can see here is that by and large you can see that she is also having hypotension. The blood pressure is towards the lower side, and that her BMI is only 17.8. Now you must have been told in your various biochemistry or even physiology classes about the BMI. So on the basis of the BMI, you classify a person as normal, or you could say underweight, or it could be overweight, or can be obese. So this 17.8, sorry, 17.8 BMI, which is shown here, it is towards the lower side. This shows that she's underweight, right? This you can see, it is showing you that the pallor is present, and again there is bilateral pedal edema which is present, right? So you can see that somehow the defects in her assimilation of nutrients has led to development of anemia as well, because the manifestation of anemia is pallor, and probably she is also having a decrease in the proteins, or she's having hypoproteinemia, which has led to edema. Right. So lab tests were ordered, and in the lab tests, these are the normal ranges, and this shows what was found in this patient. So in this patient, you can see that there is a hypoproteinemia which is visible here. Albumin is to the low, is less than the normal range. The pre-albumin is also less. Hemoglobin is also less. Hematocrit is also less. And you can see that the ferritin and the tissue transglutaminase is positive. The ferritin is also less in the tissue transglutaminase is positive. Now this should be normally negative. If this is positive, this leads to, again, this is suggestive of celiac disease. And fecal fat is increased, right? So fecal fat is increased, that means there is some problem in the digestion and absorption of fats, because of which more and more fat is being excreted out in the feces. So the endoscopy was done and a biopsy was done, in which the flat mucosa with villus atrophy and hyperplastic crypts was seen, right? So normally in the small intestine, from the structure of the small intestine, you must be remembering that the small intestinal mucosa, it is thrown into numerous fold-like projections which are known as villi. So here you see that there is a villus atrophy in this patient which was visible, and of course there were antibodies which were there, and the steatorrhea was also there, that is the fecal fat was increased. So the diagnosis of this person was made to be celiac disease, which is known as gluten sensitive enteropathy also, right? So based on the subjective and objective evidences, Meenal was diagnosed to have celiac disease, and in this celiac disease, her biopsy had shown that there was an atrophy of the villus mucosa. So here you can see this is the normal, and this is an appearance which would be there in case of a celiac disease patient. Subjective evidences were weight loss, which is unintentional, fatigability, hungry all the time, intermittent foul-smelling diarrhea. There is a family history, presence of pallor, pitting pedal edema. Objective evidences the subjective evidences were corroborated by your lab reports. It was corroborated by the endoscopic findings and by the biopsy of this person. So there was decreased hemoglobin, there was decreased albumin, there were positive antibodies, there was increase in the fecal fat, flat mucosa with a villus atrophy, and which shows an inflammatory infiltrate, right? So all these things have led you to diagnose this patient's illness to be celiac disease or gluten sensitive enteropathy. right? So she is put on gluten-free diet. Of course, medications would also be given to yeah, because she's having inflammation, so you have to give antibiotics also to resolve her problem. Right? So what is celiac disease? Basically, it is a digestive disorder that damages the small intestine. It is triggered by eating foods containing gluten, right? So there are foods which contain gluten, and this will be aggravated, or it would be triggered by eating foods containing gluten. Now, this can manifest itself in any point of time in a life. The person may be absolutely normal, and there are certain predisposing factors, there are certain risk factors which can lead to the precipitation of this illness in the later life, right? And one of them, of course, is stress. So what is gluten? It is the name given to a family of proteins which is found in all forms of wheat, barley, rye, and triticale. And these proteins help bind foods together, maintaining their shapes. So as you can see that she had given her dietary history, that she eats bread, she eats roti or chapati, which is of wheat flour. She takes soup. Now soups, they contain a lot of corn in it, and corn. And then you have she's giving you a history of eating a lot of junk food like french fries, but processed foods, etc. So all these are leading to, all these are the foods which contain gluten. And once the person is eating a diet which is full of gluten, and she has a sensitivity towards these foods, and it was precipitated in the later life, and so she was put on a gluten-free diet, right? So herself, she was telling you that she eats mostly now fruits and veggies, and she's taking this naturally occurring foods which are gluten-free, right? So now we come on to the learning objectives or the key topics for today. Just coming, okay? Okay, so that was just a case history, and I had put in that case history so that you can just get an overview of why such simple topics are also important. Because what I have seen is that you all tend to leave this topic, and this is a topic which is, you know, kind of a favorite topic for exams. Even your external examiners or the people who are taking grand viva tend to ask questions, and there are small you could say there are some factual things in this, and there are some conceptual things in this which you tend to miss out because you've not read this topic per se, right? So again, I'm emphasizing it is simple, you can easily score marks. So my advice would be to, with other topics, please do read this topic as well. Otherwise it becomes very difficult to give marks and to score marks in it. Okay, so these are the learning objectives or the key topics: the general principles of digestion and absorption, then the digestion and absorption of the nutrients, in which you have the carbohydrates, proteins, and fats, absorption of water, electrolytes, and minerals, and then we have applied aspects, in which you have the physiological aspects of diarrhea. And here at your level, you should be knowing about the lactose intolerance, the malabsorption syndrome, steatorrhea, and one I have already introduced to you is your celiac disease, which again is a part of the diarrhea. right? So first, starting off with the general principles of digestion and absorption. So there are certain principles or you can say there are certain things which are common in the digestion and absorption of most of the nutrients. So that makes it to be the general principles of digestion and absorption, right? So the first thing is that the basis for digestion is hydrolysis. Now, whatever nutrients you take in, like you have carbohydrates, proteins, and fats. So these are basically, these are complexes of their individual units, and individual units could be glucose or monosaccharides in case of carbohydrates. It could be amino acids for proteins, and it is the monoglycerides and fatty acids as far as fats are concerned. So these complexes are basically formed, by removing water molecules from them. So when these foodstuffs are ingested by us, they go from the mouth, they will travel to the small intestine. Now, depending upon the food item, it is going to either pass as such into the small intestine after, of course, having been broken down into smaller food particles by the chewing action, by the mixing and grinding action of the stomach, and by the peristalsis and the segmentation movements which are occurring in the GIT, right? Uh, and of course, there would be enzymes which are secreted. Enzymes could be secreted from the salivary glands. They would be secreted in the stomach. They would be secreted from the pancreas, exocrine pancreas. And of course, they would be present in the bile, which is secreted from the liver. And then you have the intestinal juice also, which contains various enzymes, and the small intestinal cells or the enterocytes, they also have presence of enzymes, right? So it is basically how the food is ingested, how it is broken down into smaller pieces, how do the digestive enzymes act upon it, and how the end product of digestion is produced, and how it is finally absorbed into the bloodstream and sent to various cells of the body, right? So first thing which happens, or what is the basis of digestion, is hydrolysis. Hydrolysis basically means that you are adding water which was removed when these complexes were formed. When you add water, so once the water is formed, they come into the, they are, they form smaller molecules which can then be absorbed by the small intestine, right? So for carbohydrates, you have the monosaccharides, as I told you. For proteins, it's basically the smaller peptides and the amino acids. And for fats, you have the monoglycerides and the fatty acids. Another thing in this is that there are certain mechanisms by which it occurs. Now, if you ingest a monosaccharide, then the monosaccharide can uh, be absorbed directly, right? So it doesn't need further digestion. So the general mechanisms of digestion and absorption, they follow certain principles. One is in which the foodstuff which was ingested, for example, glucose, it is not undergoing further digestion. It is not undergoing any digestion, and it is being absorbed through the enterocyte into the interstitial space, and from the interstitial space it will be going into the blood circulation. So that would complete the absorption part, right? Second mechanism is that there is a luminal hydrolysis of polymers to monomers, right? So within the lumen of the GIT, the food particle which was ingested is, after of course undergoing some mechanical breakdown, it is hydrolyzed in the presence of the enzyme, and when the optimum conditions for that particular enzyme are present, it will be broken down into the monomers. Here it is showing you the digestion of proteins which occurs in the intestine, in the GI lumen, into monomers, that is amino acids, and then it is absorbed through the small intestine. It goes to the interstitial space, and from here it will again go to the blood. Third mechanism is that uh, the digestion process has begun upstream, but it is not complete. So there are enzymes which are present on the brush border of the small intestine, where the oligomers are broken down or digested to monomers, and then they are absorbed into the blood circulation. Okay, so then एक हो गया कि किसी को उसका डाइजेशन नहीं चाहिए, उसका अब्जॉर्प्शन हो गया। दूसरा है कि गैस्ट्रोइंटेस्टाइनल ल्यूमेन में पूरा हो गया डाइजेशन। तीसरा है कि गैस्ट्रोइंटेस्टाइनल ल्यूमेन में कम, it was partly digested, and then in the presence of brush border enzymes it was broken down to monomers, and then it was absorbed, right? Next principle is that that it might be taken up by the enterocyte or by the small intestinal cell, and it is hydrolyzed within the cell itself into monomers, and this monomer is absorbed in the blood circulation. So this is another mechanism by which digestion and absorption of a nutrient can occur. And lastly, you have that the luminal hydrolysis occurs. So it is broken down into monomers. This is particularly important for the fats. So the fats which the intake of dietary fats which you take is normally triglycerides. They're broken down into their monomers, that is glycerol and fatty acid, absorbed or taken up by the enterocyte. Within the enterocyte, they are re-esterified or they are resynthesized, and this, after resynthesis, they are absorbed into the blood circulation, right? So these are the various mechanisms by means of which the digestion and absorption of nutrients can occur. These are the principal 5 mechanisms by means of which the digestion and absorption of nutrients can occur. First, of course, the monomer is ingested and it is absorbed without undergoing further digestion. Second is the polymer. It is hydrolyzed or it is digested into monomer, and then this monomer is absorbed. Third is that there is partial digestion which occurs in the lumen, which is further carried out by the brush border enzymes of the enterocyte, and then it is absorbed, the monomer is absorbed into the blood circulation. Fourth is that there is the polymer is taken up by the enterocyte. Within the enterocyte, there is the digestion which occurs, and then the monomer is absorbed. And the last is that the polymer, it is digested within the lumen. The monomers are taken up by the enterocyte. They are again resynthesized in the enterocyte, and this resynthesized, you could say the resynthesized substance is taken up by the blood circulation, right? So these are the general mechanisms of digestion and absorption. And as you can see from this, it is showing you the carbohydrate, it is showing you the protein, and it is also showing you the fats. Right? And then when you talk about the digestion and absorption of nutrients, you talk about the enzymes which are there. Enzymes, by now you must be knowing that all the enzymes, they are protein in nature. And in my lectures on GI secretions, I've told you about what are the enzymes which are secreted and from where they are secreted. So this table is basically showing you the portion of the GIT which is secreting the enzymes. You have the glandular tissues which are there, accessory glands which are there which are secreting enzymes. You have stomach, you have intestinal mucosa which also secretes digestive enzyme. Now this is showing you the enzymes which are responsible for the digestion of carbohydrate. So from the salivary glands, you have the salivary alpha amylase, which is also known as ptyalin. And from pancreas, you have the pancreatic amylase. And in the intestinal mucosa, you have presence of these enzymes, which help in the digestion of carbohydrates. These are showing you the proteolytic enzymes. Now, no proteolytic enzyme is secreted from the salivary glands. In the stomach, it is the pepsin which is secreted in the inactive form pepsinogen. Then in the pancreas, you have again the proteolytic enzymes which are secreted in the pro forms and activated in the presence of once the trypsinogen is activated, the activated trypsin will activate the other enzymes as well. And you have in the intestinal mucosa, you have the presence of amino oligopeptidase and dipeptidase enzymes, which are also proteolytic. The lipolytic enzymes are basically the lipases. You have a lingual lipase, which is there in the salivary secretions, and then you have the enzymes, the lipolytic enzymes, which are secreted by the pancreas. Right? And of course, this is enterokinase. So when I had told you about the pancreas and the pancreatic secretion, I had already told you about the details of enterokinase. Right? And in addition to that, you also have intracellular di and tripeptidases. Then there are, for the absorption, there are certain general principles for the absorption. There are various, like you have the mechanisms of digestion. You also have mechanisms of absorption. So there are 4 mechanisms which are critical for the transport of substances across the intestinal cell membrane. You have the active transport, the passive. In the active, you have both the primary as well as the secondary. In the secondary active transport, it can be a co-transport or it can be a counter transport, right? Then you have the passive diffusion. Passive diffusion can be simple diffusion or it can be facilitated diffusion. And you have another mechanism for absorption, that is endocytosis, which allows large proteins to be absorbed, especially in the babies, and it does not occur in adults. So basically, the endocytosis in humans is helping us in absorption of larger proteins, that is the immunoglobulins, and this occurs in the in your early extrauterine life, and that is it occurs in the neonatal and the infancy period, right? Sites of absorption can vary according to the nutrient which we are talking about. So as you can see, nutrient and the substance and the drugs we are talking about. So as you can see, the nutrients, including the vitamins, including the various ions, water and electrolytes, they are primarily absorbed from the small intestine. All the absorption, it occurs in the small intestine, right? Colon is basically involved in the absorption of water and electrolytes, and stomach and rectum are by and large, for the absorption of drugs, and the drugs which are noted here, you can see. So for a substance to be absorbed into the bloodstream, it must cross 8 barriers before it is absorbed into the blood or the lymph. So you have the unstirred layer, the glycocalyx, you have the apical cell membrane, the cytoplasm of the enterocyte, the basolateral cell membrane, the intercellular space between the cell and the basement membrane per se of the capillary, and you have the wall of the capillary or the lymph vessel. So these are the 8 layers through which the nutrient has to pass if it has to reach finally the blood. Why? Because from the blood is going to carry these nutrients to the various cells of the body, right? So whenever you eat, when we are eating food, what we are eating is, we say that we should eat a balanced diet. In a balanced diet, the proportion of the nutrients should be such that it is fulfilling the energy requirements and of our body, right? So this is, once you eat food, it is digested, and once it is digested, it is going to be absorbed, and absorption, it has to finally reach the blood, and in the blood, through the blood, it would be carried to various organs and to the various cells. Another thing in absorption is that most of the absorption is dependent upon the sodium electrochemical gradient which exists um, across the epithelial cell boundary of the lumen, right? So here you can see that you have the presence of a sodium potassium ATPase pump, and this sodium potassium ATPase pump is contributing to the genesis of the resting membrane potential. It contributes about 4% to the genesis of the resting membrane potential. And what is the resting membrane potential? Resting membrane potential is that potential difference exists between the interior and exterior of the cell, and the interior of the cell is negative. So primarily this negativity of the cell is due to the potassium leak channels. Then it is because of the Gibbs-Donan equilibrium, that is the presence of the non-diffusible anions which are present there. And thirdly, it is because of the operation of the sodium potassium ATPase pump, right? So this sodium potassium ATPase pump, it is extruding out 3 sodium ions for each of the 2 potassium ions which come inside. So you can see a negativity is created. So the interior of the cell is negative and the intracellular sodium ion is also less. So there is an electrochemical gradient for sodium ion which exists, right? And on the apical side of the enterocyte, you have presence of various channels and transporters through which sodium can enter, and these channels and transporters are going to help in the absorption of various nutrients. ठीक है? बीच बीच में मैं पूरा रिवाइज करवाती जा रही हूँ तुम लोगों को. If you are listening, you must have listened to the resting membrane potential also, which was not actually a part of this lecture. Right. Now we come on to the physiology of carbohydrate assimilations, right? So assimilation is a combination of digestion and absorption. Okay. So abhi tak introductory part tha lecture ka. Now we come on to this part. That is, we start off with one nutrient at a time, in which we have the carbohydrate assimilation. That is how the carbohydrates are digested and absorbed, right? So this is, just a minute. Okay, so in the carbohydrates, now this is the details you must have already read in your biochemistry classes. They must taken a number of lectures on these nutrients. So carbohydrates, they provide a major portion of the total energy needs. And here we are just bothered about what are your dietary carbohydrates. The dietary carbohydrates which are of importance can be either monosaccharides, oligosaccharides, or they can be polysaccharides. Monosaccharides, normally we take in glucose or we take in fructose. Fructose is present in fruits. Then the oligosaccharides, they comprise the dietary oligosaccharides are basically the milk sugar which you take, that is lactose, and the table sugar or the cane sugar, it has sucrose, right? And then you have the polysaccharides. In this, the polysaccharides can be divided into the digestible and the non-digestible polysaccharides. And 80 to 90% of whatever we are taking in is contributed or is formed of starch. So whatever carbohydrates, the dietary carbohydrates we take, which are digestible carbohydrates, they comprise of starches. Right? So in the digestion of carbohydrates, you have, as I told you, that the principal dietary carbohydrate is the starch. So in the dietary starch, you can see that the digestion of the starch, it begins in the presence of the salivary alpha amylase, right? So starches, they are basically, they are formed by, I think I have a diagram. So the luminal digestion, it begins with the action of salivary amylase and it finishes with pancreatic amylase. So here you can see that in the presence of this, it forms the maltose, or it is forming a polymer of glucose, which is having 3 to 9 molecules of monosaccharide glucose. And in the presence of these are the brush border enzymes. In the brush border enzymes, the digestion, in the presence of the brush border enzymes, the digestion of these polymers and these disaccharides would be completed, right? So luminal digestion, it begins with the action of salivary amylase, finishes with pancreatic amylase. Membrane digestion, it involves hydrolysis of oligosaccharides to monosaccharides by brush border disaccharidases. So here you have, for lactose, you have presence of lactase. For sucrose, you have presence of sucrase. And for maltose, you have presence of maltase and alpha dextrinase. So lactose, it forms galactose. Lactose is digested in the presence of lactase to glucose and galactose. Sucrose is digested in the presence of sucrase to fructose and glucose. And maltose is digested to glucose. Okay. I'm going faster here because these are the things which you already know. So I'll be just concentrating on the specific points and everything else. Basically, these things are also given in your books. So I will be explaining the things which are a little bit, you could say, trickier or a little bit more important, which have probably not been covered in biochemistry, right? So digestion of starch, you have for the digestion of carbohydrates, you have two parts. One is the luminal digestion and another one is the membrane digestion. So in the luminal digestion, it begins with the salivary alpha amylase and in the presence of the pancreatic amylase. So as you can see, what the amylase does is, alpha amylase, what it is basically doing is that the amylase, it is breaking down the starch into either maltotriose or alpha lipid dextrins. But the point to be noted here is that the alpha amylase, it does not act on the टर्मिनल अल्फा 1,4 लिंकेजेस, ठीक है? तो जो स्टार्चेस होते हैं ना, या तो वो स्ट्रेट चेन स्टार्चेस होंगे जो उनको अमाइलोज कहते हैं, या वो ब्रांच्ड चेन स्टार्चेस होंगे जिनको आप अमाइलोपेक्टिन कहते हो, ठीक है? तो अमाइलोपेक्टिन जो है, इट कंप्राइजेस this 80 to 90% of the dietary starch. Alpha amylase per se is termed as an endoenzyme. Why? Because it is acting on the interior bonds, and in the interior bonds it's acting on the alpha, it is acting on the 1,4 alpha linkages which are on the inner side. So they will not act on the terminal parts of the स्टार्च. ठीक है, दूसरा ये अगर आप ब्रांच चेन स्टार्चेस की बात करोगे तो ब्रांच्ड चेन स्टार्चेस में अगेन दिस विल नॉट एक्ट ऑन द टर्मिनल पार्ट्स even if they are in straight chain, and it will also not act on the alpha 1,6 linkages which are the branching points, and it will also not act on the alpha 1,4 linkages which are adjoining the branching parts. ठीक है, तो अल्फा अमाइलेज को एंडो एंजाइम कहते हैं. इट इज अ टाइप ऑफ एन एंडो एंजाइम. Why? Because it acts only on the interior bonds. It does not act on the terminal 1,4 linkages, and it does not act on the branching alpha 1,6 linkages. ठीक है. Final product of carbohydrate digestion is monosaccharides. So, right, the final product would be monosaccharides. Mostly it is glucose, because mostly the intake of dietary carbohydrates is the form of starch, and starch, as you've seen, is broken down into finally into glucose. But we also take in fruits, and we also take in sugar, and we also take in milk, right? So in that case, in case of the milk or the milk sugar, it is broken down to one molecule of lactose is broken down, yields one molecule of glucose and one molecule of galactose. Sucrose yields one molecule of fructose and one molecule of glucose. So absorption of carbohydrates, once the carbohydrates have been digested into monosaccharides, they are going to be absorbed. Absorption will occur in the small intestine, and this is the rate limiting step. Glucose and galactose, they are absorbed by the process of secondary active transport by means of the sodium dependent glucose transporter 1, and energy for this comes from the sodium potassium ATPase pump. Fructose is using another mechanism for absorption. It is by means of facilitated diffusion, and it occurs through the glucose transporter 5. It does not require energy, it requires a concentration gradient. जहाँ diffusion आया वो पैसिव होगा तो वो along the concentration gradient होगा या along the electrical gradient होगा. यहाँ पर आप एक न्यूट्रिएंट की बात कर रहे हो, एक मोनोसैकेराइड की बात कर रहे हो, तो that would be your concentration gradient which will be helping or enabling. but क्योंकि facilitated diffusion है तो यहाँ पे carrier होगा, और वो carrier transporter कौन सा होगा? वो GLUT5 transporter है या glucose transporter 5 है, right? So this is showing you a model of how glucose and galactose absorption occurs. Here you have a carrier protein which is present, which is known as the sodium glucose transporter 1. क्योंकि ये secondary active transport से हो रहा है तो इसके लिए energy कहाँ से आ रही है? Energy आ रही है सोडियम के ग्रेडियंट से. सोडियम का ग्रेडियंट कैसे प्रोड्यूस हुआ है? सोडियम का ग्रेडियंट प्रोड्यूस हुआ है क्योंकि ये जो एपिकल साइड है और जो बेसोलैटरल साइड है वो डिफरेंट होती है, वहां पे डिफरेंट प्रोटीन्स प्रेजेंट होते हैं, डिफरेंट ट्रांसपोर्टर्स प्रेजेंट होते हैं. सो ऑन द बेसोलैटरल साइड ऑफ द एंटेरोसाइट यू हैव द प्रेजेंस ऑफ सोडियम पोटेशियम एटीपीएस pump which causes extrusion of 3 sodium ions for each of the 2 potassium ions which are pumped inside. This causes a gradient of sodium. It causes a deficiency of sodium here, so this provides the energy for the co-transport of sodium and glucose, which occurs on the apical side of the enterocyte, right? So this occurs by means of sodium glucose transporter 1. Sodium binds, glucose binds, both of them are transported to the inside by conformational change हो गया. Sodium will go out by sodium potassium bond, glucose will come out of this cell by facilitated diffusion into the bloodstream, and this protein, transport protein, would be recycled back. So this is how absorption of monosaccharides occurs in the upper small intestine. You have for the sodium, for the glucose and galactose, they are using the same mechanism, only monosaccharides are being absorbed. In the monosaccharides, you have glucose, galactose, and fructose. Glucose and galactose are absorbed by sodium glucose transporter 1 through secondary active transport mechanism, and they come out of the cell on the basolateral side by GLUT2, which is by means of the facilitated diffusion. Okay. Fructose आएगा अंदर through GLUT5, and there can be a separate transporter, but it is still not known clearly. So there are two distinct groups of exhaust transporters classified based on energy dependence. Those which flow down again along the concentration gradient, that is the facilitated diffusion, and those which are against the gradient using the sodium electrochemical gradient, you have the SGLT1. Okay? So here you have the GLUT2. This is the basolateral side and this is the apical side, as you can see. So now, once you know about the assimilation of carbohydrates, we come on to the abnormalities of carbohydrate assimilation. So there can be deficit in the digestion or absorption or both, right? And lactose intolerance is one of them. It is an acquired lactase deficiency or primary adult hypolactasia. Symptoms are abdominal cramps, bloating, diarrhea and flatulence. क्यों होगा? क्योंकि लैक्टोज जो है उसके लिए लैक्टेज एंजाइम चाहिए. लैक्टेज नहीं होगा तो लैक्टोज डाइजेस्ट नहीं होगा. लैक्टोज डाइजेस्ट नहीं होगा तो वो absorb नहीं हो पाएगा. It will remain within the intestinal lumen and it will add to the osmotic load of the intestinal contents, right? The diagnosis would be by means of the hydrogen breath test. Cause is because of the absence of the brush border lactase, and it is the treatment for this is that the dairy products should be avoided. This is rare, that is the lack of glucose galactose carrier. It is rarer, and if it is present, if it is indeed present in a child or in an infant or a baby, then that child is fed fructose instead of glucose and galactose, right? So now let's see, I started off with a case. In the middle also I've put in one case today, just to give you the clinical relevance of this topic, right? So let's apply the physiology knowledge for carbohydrate assimilation, right? So here again you have Akash. He's a 20-year-old engineering student. During the past 6 months, he has experienced several bouts of severe abdominal bloating, flatulence, and cramps followed by diarrhea. Right, so here you have a patient who has come to see you. He is a 20-year-old student in an engineering college. And he says कि मैं ठीक था, but 6 महीने से मुझे, I'm having severe abdominal cramps and flatulence is there, and there is distension of the abdomen or the bloating, and this is followed by diarrhea. At first, he thought these episodes were caused by stress of his demanding academic program. Now, you all are also students. You will be having your cent-ups, you would be having your professional exams. So by and large, you would be giving exams for the next 2 months, right? So stressful, I agreed it is stressful. It can, if you've not been studying for the whole year, towards the end your syllabus is huge. It is huge actually, right? And you can start having diarrhea, because a stress can also cause diarrhea. It can cause constipation, so any type of thing can happen. So you say nahi nahi yaar, ye to because of stress, I have not studied anything, so it's happening. However, he noticed that the symptoms occurred approximately 1 hour after he drank milk or ate ice cream, right? खुद ही उसने बताया कि लेकिन I have noticed this on a visit home. Now you must have gone for a Diwali halls to your place, and so he must have also gone, and he mentions it to his mother, and his mother says, don't you know that your father and I have never been able to drink milk? So again, there is a genetic predisposition to it. So he was taken to a physician who examined him, found him in good health. ऐसा तो कुछ नहीं लग रहा. But क्योंकि उसको symptoms से, so the physician ordered a lactose hydrogen breath test. So he was ordered a lactose hydrogen breath test. So it is basically an oral challenge. जैसे GTT होता है, तो इस तरीके से उसको lactose दिया गया और उसको उसकी serial recordings करी गई of the hydrogen ion of hydrogen in his breath. So it was found that he had lactose intolerance. So lactose hydrogen breath test confirmed that he had lactose intolerance. His fecal osmolar gap was measured. It was found to be elevated. As a further confirmation of the diagnosis, he was asked to abstain himself from the dairy products, and so he had no episodes of bloating, cramping, or diarrhea during that time period. So it was further confirmation was taken that you stop drinking milk, you stop having dairy products, and you see how you feel, whether you have these symptoms or not. And then it was again, it's kind of confirmed that he has lactose intolerance. Right, so what is basically lactose hydrogen breath test? In this lactose hydrogen breath test, what is done is basically that the lactose is ingested by the person or the patient, and normally this lactose is going to be hydrolyzed into glucose and galactose by the brush border enzyme, that is lactase. लेकिन अगर ये lactase नहीं होगा तो क्या होगा? Incomplete digestion होगा और ये कोलन में रीच करेगा. कोलन में क्या होता है? You have presence of colonic bacteria which is present there. So this microbiota is going to ferment it with production of hydrogen, and methane will also be formed, as well as carbon dioxide would also be formed. Now this is going to be picked up by the blood, and via the portal circulation it will go to the lungs, go to the systemic circulation and reach the lungs, from where it will be excreted via the lungs. And this is going to be picked up in your breath test, and there are values. So if it is above a certain threshold, then it is said to be positive, and it is going to be confirmatory for lactose intolerance. Right, so you can interpret it like, if it is less than 20 parts per million, then it is normal lactose assimilation. If it is more than 20 parts per million, increase in hydrogen is present, so it points towards the lactose malabsorption, and it shows lactose intolerance. So effect of lactase deficiency on plasma glucose levels and hydrogen in breath. So this is showing you a normal plasma, this is showing you a normal lactase activity. Normally the lactase is present. So once the lactose is ingested, what happens is the plasma glucose level increases, right? So again, this is showing you that the lactase activity is normal. And since it is broken down into glucose and it is broken down into this galactose, so what happens is that it is kind of the lactase, the hydrogen ion is excreted by lungs would be below 20 parts per million. But in case of lactase deficiency, what will happen that once the lactose is ingested, so this lactose, once it is ingested, then the glucose levels you can see does not increase so much, and so this is going to be metabolized by the colonic bacteria, and so the hydrogen would increase and this would be excreted out via the lungs. Okay? But इसका response to ingested glucose would be normal. So here you can see that glucose and lactose are both following the same trajectory, but here there is a separation. So this shows that the lactase enzyme is required for digestion of lactose. Another term I used was fecal osmolar gap. Now, maybe it might be required for some of the good students if you can remember this, but I have put in because it's an interesting concept, like you have an iron gap in your renal system, so also you have a fecal osmolar gap, right? The fecal osmolar gap kya hota hai? It refers to unmeasured solutes in the feces. Unmeasured solutes in the feces, and it is useful, this concept is useful in understanding the pathophysiology of diarrhea, right? Fecal osmolar gap. What is this fecal osmolar gap? This basically measures the total osmolarity and sodium and potassium concentration in a stool sample. Okay? So ये fecal osmolar gap is measuring the total osmolarity and sodium and potassium concentration. So what you do basically in this is that you take the sum of sodium and potassium concentrations, multiply it by 2, right? So to account for the balancing anions. इसको 2 से क्यों करा? क्योंकि वो balancing anions के लिए, जो ये cations हैं तो उतने ही anions होंगे, right? The difference between the total fecal osmolarity and the sum of 2 times the fecal sodium is the fecal osmolar gap. Now stool का osmolar gap normally कितना, plasma osmolarity कितनी होती है? Normally होती है 290, और यही osmolarity जो है ये आपकी इसकी होती है, stool की होती है normally, ठीक है? So the normal gap range should be between 50 to 100. So when you take this osmolar gap, the normal, how is the osmolar gap taken? You take the stool osmolarity is equal to 2 times the sum of sodium and potassium concentrations. You subtract this from 290, which is the plasma osmolarity, and you get a gap that is in the range of 50 to 100. अगर less than 50 है तो secretory diarrhea, और more than 100 है तो osmotic diarrhea है, because it accounts for osmolytes like carbohydrates most commonly and also salts. इसका मतलब कि वो absorb नहीं हुआ और वो measure भी नहीं हो सकता, तो इसलिए उसमें gap ज्यादा दिखा रहा है. तो इसका fecal osmolar gap was higher. This shows that there is a problem in assimilation of carbohydrates. So it was elevated because of the presence of unabsorbed lactose, which contributed to the total osmolarity of the stool. Right? Now we come on to the next nutrient, that is the protein assimilation. So physiology of protein assimilation, this is nothing much to do in this. You know the enzymes, you have the pepsin, then you have the endopeptidases and the exopeptidases. Endopeptidases are secreted from, this is basically the pancreatic juice contains them. They act on the interior peptide bonds, so they are known as endopeptidases. Exopeptidases, they hydrolyze the amino acids at the carboxyl ends, so they are known as exopeptidases. So proteins in the presence of pepsin, they are digested into proteoses, peptones, polypeptides, and these are further digested into their amino acids in the presence of endo and exopeptidases. And this is activation and destruction of proteases. I've already told you that why the proteolytic enzymes, they do not auto digest the GI because of the presence of certain inhibitors which prevent their activation within the lumen. So these proteins are digested into the di and tripeptides, into large peptides and free amino acids. So luminal digestion produces 40% amino acids and 60% small peptides, and then these are digested further by the brush border enzymes which are present. Those are the peptidases which are there, or they can be carried directly in the form of the di and tripeptides into the enterocyte, digested further by the cytoplasmic peptidases, and then absorbed as amino acids. So if you remember from the general mechanisms of digestion and absorption, I told you that for proteins you have that they can be absorbed as the monomers, that is the amino acids. You have carriers for them and it can be absorbed into the general circulation. The oligopeptides can be absorbed. They had a different carrier and then they are further digested in the cytoplasm by cytoplasmic peptidases and then absorbed as amino acids, or small amount of it can be absorbed in the form of dipeptides and tripeptides. So absorption of proteins, in the absorption of proteins, you have absorption of amino acids and you have absorptions of di and tripeptides. For amino acids, it is the secondary active transport, which is mostly sodium dependent. And you have for di and tripeptides, you have another set of transporter, which is known as pepti-1 or peptide transporter 1. So instead of sodium, it uses hydrogen ions, right? So amino acids are absorbed primarily by the same process as there was absorption of the glucose and galactose, and whereas for the di and tripeptides, you have the absorption which occurs by means of the transporter, which is known as pepti-1 or the peptide transporter 1. Okay. So this is showing you the absorption of amino acids which occurs in the small intestine by the process of secondary active transport. You have a different set of transporter proteins on the apical side and different set of transporters on the basal side of the membrane of the cell. And so here, like you had for the sodium glucose co-transport, so you also have sodium amino co-transporter which is present, and the energy for this is provided by the gradient which is established by the sodium potassium ATPase pump, right? So another thing which is you should be knowing at this stage is that why in the oral rehydration syrup, when a person has diarrhea, then you would normally आपने ads भी देखे होंगे टीवी पे, उसमें कहते हैं नमक चीनी का घोल बना के दो. Why salt and sugar solution should be given, or why does oral rehydration syrups, they contain a combination of sodium and glucose? It is because the absorption of glucose is occurring by means of sodium glucose co-transporter. So the presence of sodium in the oral rehydration syrup is going to facilitate, or would you could say speed up the absorption of glucose. The absorption of oligopeptides, as I told you, di and tripeptides, it occurs by means of another transporter, that is peptide transporter 1. So here you see that instead of the sodium ion, you have the hydrogen ion. So when there is a presence of a di or tripeptide, it will be taken up on the apical side of the small intestine by this peptide transporter 1, in which instead of sodium you have the hydrogen ion, and this is taken up, and from here it will be broken down into amino acids by peptidases, intracellular peptidases, and then it will be absorbed. So here you can see the advantage of peptide absorption. You can see that this is a faster process as compared to the absorption of free amino acids. So this graph is basically showing you the kinetic advantage of peptide absorption. So you have abnormalities of protein assimilation which occur. So they can be pancreatic insufficiency, which can lead to the disorders of protein digestion and absorption. You can have absence of trypsin, congenital, or it could be in Hartnup disease, in which there is a defect in the congenital defect in the transporter for amino acid. So this proves that there is a separate carrier system for di and tripeptides. So this is showing you in the Hartnup disease what happens is that as you can see, if the normal subjects, the amino acid absorption is uh, normal, but in case of Hartnup disease, there is a specific transporter which is not present for phenylalanine, and this shows that there are separate set of transporters for different kinds of amino acids also. In cystinuria, what happens in case of Hartnup disease, you have it cannot absorb neutral amino acids like tryptophan and phenylalanine, whereas in case of cystinuria, it is basically the basic amino acids which are not absorbed, and this can precipitate the kidney stones, the stones in the or calculus formation within the renal system or within the kidneys. Okay. Then you, as I told you, you have allergies to food. I introduced the class with the help of a case study in which there was a food item which was foods which were causing allergy. So per se, these are known as food allergies. You can have allergy for lactose or milk because of the deficiency of the lactase enzyme. You can have allergy to gluten because of the celiac disease, and similarly you can also have foreign proteins which enter the circulation. They provoke formation of antibodies, and they can cause this antigen antibody reaction can cause allergic symptoms. Now coming on to the fat assimilation, again very important. You can get long question on either of them. You can get a long question on describe the physiology of digestion of carbohydrates, digestion and absorption of carbohydrates, or you can get digestion of carbohydrate, fats and proteins. कैसे भी आ सकता है, digestion and absorption of fats per se. तो ये पूरा long question आता है usually. Okay. Dietary fats, most abundant are the triglycerides, and in small quantities you have dietary fats in the form of phospholipids, cholesterol esters, and cholesterol. Essentially all fat digestion, it occurs in the small intestine. ठीक है, प्रोटीन का और कार्बोहाइड्रेट्स का डाइजेशन ऊपर भी हो रहा है. Like protein ka, it starts in the stomach. For carbohydrate, it starts in the mouth itself. But as far as fat is concerned, almost all the digestion is occurring within the small intestine. Right? So in the mouth, it is basically the mechanical digestion. That means when you are chewing chewing and then swallowing. So the mixing action, it causes, mixing or the mechanical digestion occurs, that it is breaking down the larger fat particles into smaller fat globules, right? So it's breaking up the large fat particles to the smaller ones. Limited enzymatic activity occurs here at the mouth level. In the stomach, again, it is contributing to the mechanical digestion by mixing and churning action, and limited digestion occurs because here again it is until and unless it's acted upon by the bile salts, it's emulsified, the surface area for digestion is not available for the fat particles. In the small intestine, it is basically the emulsification which occurs in the presence of the bile salts and lecithin, which increase the surface area available for digestion and digestive enzymes to act upon it, and then it is acted upon by the pancreatic lipases, and once it is acted upon by the pancreatic lipases, it's going to form micelles which will help in the absorption of the fats. Okay, so basic steps in lipid assimilation. Most dietary lipid, it is neutral fat or triglyceride, and three main processes must occur for triglyceride to be absorbed into the blood. ठीक है, तीन मेन प्रोसेसेस अकर होने चाहिए. क्या है वो प्रोसेस? फर्स्ट स्टेप इज emulsification should occur. So first step in the assimilation of lipids is that it has to be emulsified. And what is emulsification? Large aggregates of dietary triglycerides are broken down into smaller fat globules. So this is in the presence of the lecithin and bile salts which are present in the bile. Second step is that once it is emulsified, the emulsified fat is acted upon by the lipases, the colipases, to yield monoglycerides and free fatty acids. To yield monoglycerides and free fatty acids, both of which can diffuse into the enterocyte. So both of these can go into the enterocyte, where the reconstitution will occur of the triglycerides and of the free fatty acids and monoglycerides into triglycerides. And then they can either, depending upon the number of carbon atoms, they can either go directly into the blood, or they can be go into the lymphatic circulation via the chylomicrons. Right? So first step in the assimilation of fats is the emulsification of fat by bile salts and lecithin. First step, this is the first step in the digestion of fats. क्यों जरूरी होता है emulsification? इसलिए जरूरी होता है because fat जो है वो water insoluble होता है. ठीक है, fat is water insoluble. और जितने भी जूसेस सिक्रीट हो रहे हैं बॉडी में, या जो डाइजेस्टिव जूसेस हो रहे हैं, वो वाटर के साथ हो रहे हैं. ठीक है, सो यू have to produce a fat in a way, you have to convert fat into a way which can be water soluble. तो उसको water soluble करने के लिए ये सारे processes हो रहे हैं. ठीक है, so it breaks the fat globules into very small sizes so that water soluble digestive enzymes can act on the globule surfaces. Most important enzyme for digestion is pancreatic lipase, and these are water soluble, can attack the fat globules only on their surfaces. Okay? So emulsification will be done by bile salts and lecithin. Now bile salts and जो bile salt का structure होता है उसमें क्या होता है कि एक polar part होता है और एक non polar part होता है. जो polar part है वो periphery पे present होता है and this is highly soluble in water. और जो नॉन पोलर पार्ट है वो सेंटर में होता है विच इज हाईली सॉल्युबल इन फैट. तो ये जो बाइल सॉल्ट है ये इमल्सिफिकेशन में हेल्प करेगा बिकॉज इसकी कैरेक्टरिस्टिक ऐसी है कि वो it has both hydrophobic as well as hydrophilic ends. Right? So here you see you have if you mix oil and water they don't mix. लेकिन अगर बाइल सॉल्ट और लेसिथिन मिक्स है प्रेजेंट तो वो क्या करेगा कि वो उसको वाटर में miscible कर देगा. Right? So if it is emulsified, it's broken down into small pieces, it will enable it to be digested by the lipases because it is making it water soluble. So what happens is the fat globule in the presence of bile salt, you can see this is, of course these are exaggerated sizes. So towards the periphery you have the hydrophilic sides and towards the center you have the hydrophobic side. So it forms small globules of fats with the fats present in the center of these micelles. So triglycerides, they are digested by the pancreatic lipase after it has been emulsified. It is acted upon by the pancreatic lipase, and it converts it into fatty acids and monoglycerides. In addition to this, you also have presence of cholesterol ester hydrolase, which digests the cholesterol esters into cholesterol and fatty acids, and you have phospholipase A2, which digests the phospholipids into lysolecithin and fatty acids. So what is the role? एक तो पहला जो bile salts का function है वो emulsification में है, that it is initiating the digestion of fats by emulsification. Second is it keeps on, it also helps in aiding the digestive process, क्योंकि एक बार digestion start हुआ तो उसमें क्या होगा, जब fatty acids और monoglycerides, free fatty acid और monoglyceride अगर वहाँ accumulate होंगे, उनको remove नहीं करा तो they will block further digestion of fats. So you have to remove those free fatty acids and monoglycerides which have been formed. और वो remove कैसे होंगे, वो again bile salts will help in aiding that. So it forms a small cylindrical globules which are known as micelles, and this helps the fat globule to dissolve in water of the digestive fluids and remain in stable solution until the fat is absorbed into the blood. तो एक तो उसने उसको हेल्प करा छोटे फैट ग्लोब्यूल्स बनाने में, दूसरा उसने हेल्प करा उसको स्टेबलाइज करने में कि जो भी डाइजेस्टिव प्रोडक्ट्स वहां पे accumulate ना हो, वो उससे क्या करता है, ग्लोबुलर स्ट्रक्चर्स बनाता है जिसमें these things go into the center and you have the hydrophilic ends. The hydrophilic portions are towards protruding from the exterior. ठीक है. Third thing which the bile salt does is that it helps in ferrying of these digested products, right? Ferrying means जैसे ferry एक place से दूसरे place पे ले जाती है, तो fat जो है अपने आप नहीं move कर सकता, उसको you have to make it move from one place to another, otherwise it will not be able to reach the unstirred layer of the intestine, right? So bile salt in micelles also act as a transport medium to carry monoglycerides and free fatty acids, and it takes them to the brush border of the intestinal epithelial cells. Okay? So what it is doing is it is also helping in transporting these triglycerides and the free fatty acids and the monoglycerides to the intestinal epithelial cells. And once it takes it there, then it is again released. The bile salts are again released back into the chyme to be used again and again for this. ठीक है, तो ये आपका एक emulsification हुआ which was done by the bile salts and lecithin. Then this was acted upon by the pancreatic lipase. Monomers were formed, monoglyceride and free fatty acids were formed. The bile salts, they formed micelles so that they don't accumulate here, these products, and it takes them to the intestinal epithelial cell. Once it has taken them, this is absorbed by the intestinal epithelial cells, and the micelle is being recycled for further emulsification. ठीक है, अब जब ये हो गया तो अब इसका अब्जॉर्प्शन कैसे होगा? डाइजेशन तो हो गया, फ्री फैटी एसिड हो गए, मोनोग्लिसराइड हो गया, ठीक है, तो अब ये एंटेरोसाइट में कैसे एंटर करेगा? एंटर करता है बाय पैसिव diffusion, right? Lipids are they are entering the enterocytes by passive diffusion. Once they enter it, what will happen is they would be rapidly esterified to maintain a favorable concentration gradient from lumen into the cells. ठीक है, तो जैसे ही ये एंटर करेगा ये स्मूथ एंडोप्लाज्मिक रेटिकुलम में इसको फिर से उसका रीएस्टेरिफिकेशन हो जाएगा और वो फिर से ट्राइग्लिसराइड्स बन जाएंगे। तो उससे क्या होगा कि फ्री फैटी एसिड फिर फ्लो कर सकता है अंदर की तरफ। फैटी एसिड्स लेस देन 10 to 12 carbon atoms, they are water soluble. They will pass through the enterocyte unmodified and they will go into the portal circulation. लेकिन जो fatty acids more than 10 या 12 carbon atoms है, they are insoluble, so they will be re-esterified, coated with a layer of protein, cholesterol and phospholipids in the rough endoplasmic reticulum. They will form chylomicrons, and these chylomicrons will leave the cell by exocytosis, and from here it will enter the lymphatic circulation. ठीक है? So this is how fat absorption will occur. So this is showing you a summary of how the fat absorption is occurring. You have the presence of a fat droplet, then you have the presence of the bile salts and the lecithin, which will form, which will lead cause emulsification of this fat droplet, break them down into smaller pieces, and this will be acted upon by the pancreatic lipase. The free monomers will be released, and these free monomers will be aggregating into the micelles. The micelle will transport it to the enterocyte. In the enterocyte, less than 10 to 12 carbon atoms would be absorbed into the general circulation, whereas more than 10 to 12 would be re-esterified, and uh, once they are re-esterified, they will be coated with the proteins, form chylomicrons, which will enter into the lymphatic circulation by the process of exocytosis. Right? So, large fat droplet emulsification occurs in the presence of bile, which contains bile salts. It forms emulsified fat droplets. Now, these emulsified fat droplets will be acted upon by the lipases, broken down into fatty acids and monoglycerides. So there is enzymatic digestion by pancreatic lipase. Now, once they have been digested, they will be ferried in the form of micelles to the intestinal epithelial cells. So fatty acids and monoglycerides resulting from fat digestion leave micelles. They will enter the epithelial cell. In the epithelial cell, the short and medium chain fatty acids and glycerol will be absorbed into the blood via capillary, okay, which is not shown in the figure, and the long chain fatty acids and monoglycerides will form triglycerides and are transported into the chylomicrons, extruded out by exocytosis into the lymphatic circulation, into the lacteal or the lymph vessel. See, so chylomicron की life cycle क्या है? It is formed in the enterocyte, packaged by Golgi apparatus, secreted by exocytosis into interstitial space, enter the central lacteal of villi, transported to venous system via the thoracic duct. Lipoprotein lipase will act on it, and it will works with it, the lipoprotein C, to degrade the triglycerides to free fatty acids and glycerol within the chylomicron. These are resynthesized to triglycerides for storage. The chylomicron remnant is phagocytized in the hepatocytes. If there is a deficiency of lipoprotein lipase, then it leads to hypertriglyceridemia. Right? So what will happen and why? If there is a familial lipoprotein lipase deficiency, it's a rare genetic disorder in which there is a genetic deficient activity of lipoprotein lipase, and this will cause accumulation of large quantities of fats in the blood. Another thing in the defect of fat assimilation is that more fecal fat will be present. It would be bulky, fatty, clay-colored stool, and this condition is called as steatorrhea. This type of stool is known as steatorrhea, and these are the common causes of steatorrhea. ये सब मैं आपको already I have told you when I was discussing the GI secretions. Malabsorption, again, now you are familiar with it. Malabsorption as a general phenomenon is defined clinically in terms of fat malabsorption because you can measure the fecal fat. Malabsorption can be because of disorders of the motility of the GIT, because of the disorders in the digestive process, or because of the disorders in the absorption process, right? So motility disorders, it is moving too rapidly through the GIT, is not, so it leads to malabsorption. Digestion, there can be deficiency of specific enzymes which leads to the defect in the assimilation of that particular nutrient. Absorption disorder, there can be defect in the carrier proteins, the transport proteins for particular nutrient, and so it will not be absorbed, right? Or this absorption disorder can be tropical and non-tropical sprue, and it can be because the small intestine has been resected, the person had intestinal obstruction, uski intestine ko kaatna pada. Up to 50% it will pose no problem, but more than 50% resection will lead to absorption disorder. So sprue is, what is sprue? Sprue is basically you have the diseases that result in decreased absorption even when food is well digested is classified as sprue. So these are absorption disorders. Non-tropical sprue, I have told you, the celiac disease, it destroys the microvilli and villi. Tropical can be because of certain infections, and in this a common infection is your Giardia lamblia, which affects the absorptive capacity of the small intestine. Then we come on to, once we are through with the carbohydrate, fats and proteins, now you come on to the fluid and electrolyte absorption and secretion. So like you must have read in the kidneys about the water balance, कि कितना intake है, कितना output है. So how much intake should be there and how much output should be there to maintain a water balance. इसी तरीके से you have a balance in the GI system also, how much volume of fluid is entering the gut and how much of it is leaving the gut. So basically this is showing you the fluid balance in the GIT, and it is only about 100 to 200 ml of fluid this is the volume which is excreted out in the feces. So how does water move? Water का movement जब भी होगा वो passive process से होगा, और passive process में water में it is the osmotic or the osmosis of water which occurs. So water moves into or out of the gut lumen by diffusion in accordance with the osmotic forces, right? So अगर chyme hypotonic है तो water उससे flow करेगा into the circulation, और अगर chyme hypertonic है तो water will enter into the lumen of the intestine, right? Sodium absorption causes water absorption. तो आपने देखा होगा कि जितना भी absorption बताया उसमें mostly it was the sodium which is moving the various nutrient molecules, right? So sodium is absorbed by the epithelial cells. This creates a negative electrical potential which provides gradient for chloride uptake, और क्योंकि ions flow कर रहे हैं तो उसकी isotonicity को maintain करने के लिए water will flow along with it. So sodium absorption in small intestine, it can be absorbed through by 4 mechanisms. One is sodium diffusion through water-filled channels. It is the sodium is being absorbed through the water-filled channels. दूसरा है कि co-transport हो रहा है उसका either with glucose या with amino acids which I've already described, या उसका co-transport हो रहा है with chloride ion. Again, this I described when I was telling you about the pancreatic juice secretion, and then you have counter transport which is in exchange for the hydrogen ion which can occur. So chloride follows electrical gradient, and once the sodium and chloride are moving in, they will tend to pull in the water also. 15% of the total body sodium is absorbed each day by intestine, and this is just showing you certain values, how much is present in the diet, how much is secreted in the small intestine, how much is being absorbed, and how much is being excreted out in the feces, right? So if there is any defect in the absorption of sodium, it can lead to rapid sodium depletion and death. Water secretion, it occurs by the small intestine, as I have already told you. It is by two processes which establish an osmotic gradient which pulls the water into the lumen of the intestine. So you have increased osmotic pressure which is resulting from digestion of foodstuffs, and you also have that the Krebs cells, they are actively secreting electrolytes, which in turn leads to secretion of water. Okay, so water secretion by Krebs cells, it is driven by chloride secretion. So as you can see, the apical lumen contains a cyclic AMP dependent chloride channel, ठीक है, जिसको आप कहते हो cystic fibrosis transmembrane conductance regulator. Now this I told you when I was telling you about the pancreatic secretion, तो इसको मैंने आपको काफी डिटेल में पढ़ाया था, जिसमें I told you about the secretin and the cholecystokinin also. So mutations in this gene for ion channel will result in cystic fibrosis. Cyclic AMP activates the chloride channel. Sodium will follow this electrical gradient, and hydrogen will move, the water will move along the osmotic gradient. तो ये जो मूवमेंट होता है ये ट्रांससेल्युलर होता है, और ये जो मूवमेंट होता है इसको आप पैरासेल्युलर मूवमेंट कहते हैं. What happens in cholera? Cholera causes the increase in the activity of the cyclic AMP driven chloride channel, and so it leads to more and more secretion of chloride, more and more secretion of sodium into the lumen of the GIT, and this will cause pulling of water. इसलिए cholera के patient में watery diarrhea होता है. These are all, explain what will happen and why, give the physiological basis or give the pathophysiology of this disorder. Okay, so lots of questions can be made from this. Lots of MCQs can also be made. So diarrhea, it is the third leading cause of death by disease worldwide. You have various types of diarrhea. It can be secretory diarrhea, in which case you have the cholera toxin and rotavirus, I've told you. Osmotic, which can occur in case of a pancreatic disease, celiac disease, lactose intolerance, short bowel syndrome, or it could be motility related diarrhea, and there's diabetic neuropathy or vagotomy, or there can be an inflammatory diarrhea. So the diarrhea, the patient will present to you with the symptom of diarrhea, and you have to basically make a diagnosis that what is the cause for this diarrhea, and accordingly treat the patient. So vagotomy basically decreases peristalsis and a change in gastric emptying pattern, which can lead to dumping syndrome and diarrhea. Now this I'll also tell you when I'm telling you about the motility, GI motility. So rotavirus is a type of, it causes a type of secretory diarrhea, and these days vaccines are also available for the rotavirus infection, which are given usually to the children, and this causes basically malabsorption occurs in these subjects because enterocytes are damaged, and the sodium dependent glucose transporter is disrupted, which leads to decrease in the absorption of the glucose and the galactose, and hence there is an increased osmotic load, and this increased osmotic load will lead to retention of water in the lumen and cause diarrhea. Okay. Cholera, I have already told you, it stimulates the secretion of water and electrolytes, and a person can lose 10 liters or more. So you can see that person can go into a state of hypovolemic shock and can land up in trouble, right? So these are seems to be simple things, but can be fatal too. And oral rehydration solutions are given, and glucose is given along with the electrolytes, primarily the sodium, and because sodium helps in the absorption of glucose, galactose, amino acids, so oral rehydration syrups usually contain a combination of these. So just to summarize, this is showing you the digestion and absorption of carbohydrates, proteins, and fats. Here you can see it's the mouth, the stomach, the small intestine, and the intestinal lining. The starch and the glycogen present in the food acted upon by salivary amylase, pancreatic amylase, and they are broken down into disaccharides, and from the brush border disaccharidases into monomers, and then they will be absorbed. Proteins, the digestion begins in the stomach, and they are hydrolyzed into the protein products, the peptones, the proteoses, and the polypeptides, which are broken down by the pancreatic proteolytic enzymes, the endo and the exopeptidases to form small peptides, amino acids, and then you have also the intracellular peptidases which are present and which are breaks these peptides into amino acids. The fats, once they are taken up by the chewing action, by the mixing and grinding action of the stomach, they are broken down into smaller pieces, further broken down by means of the emulsification of fats, which occurs in the presence of the bile, which comes from the liver, which is stored in the gallbladder. So here they will be acted upon by the pancreatic lipases, and it will be absorbed from the small intestine. Okay, so this is showing you a summary of the nutrient absorption. This is that the carbohydrates are primarily absorbed from these carbohydrates, proteins, lipids are mainly absorbed in the duodenum and the jejunum, and there is very little absorption from the basically you could say little absorption from the distal part of the small intestine. Whereas the bile acids, their maximum absorption occurs at the level of the ileum. And for the other substances like calcium, iron, and folate, you can see that it is being absorbed in the upper part of the small intestine, whereas the cobalamin is primarily absorbed from the ileum. So that completes the two competencies which I covered today. One was your digestion and absorption of nutrients, and you had the physiological aspects of diet, right? Uh, so I think it was simple. So I introduced the topic with a case. I've given you two case histories today, one of a celiac disease, another one of a person suffering from lactose or having lactose intolerance. Okay. So anything which is not clear, again I'm emphasizing, you can ask through your CRs to me, or you can even come to my room in the department, and if you need any further explanations. Okay. So have a nice day. Tomorrow I'll be taking your lecture at the usual time.